Welcome, everyone. It's great to see folks after our summer break. As you know, I'm Dr. Tara Kieran. I'm the Vice Chair for Quality and Innovation at the Department of Family Community Medicine at the University of Toronto. I'm also a family doctor at St. Michael's Hospital. I'm really delighted that our department at U of T is able to continue to collaborate with the Ontario College of Family Physicians to bring you these COVID-19 community practice sessions now in our third year. So over to you, Mahalay, to introduce the session.
Thanks, Tara, and good morning, everyone. Welcome. It's so nice to have you back with us as we are preparing for the fall. We have a great session for you today, and I'd like to just take a moment to thank both of our panelists for being here with us. Next slide, please. And just a reminder that this is a Main Pro accredited session. Details will follow. Okay, next slide. So I'll just move on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples. Okay, next slide. So I just wanted to take a moment to speak about this really interesting CBC article that touches on the impact of climate change on food security, particularly within our Indigenous communities across the country. So essentially, with changing weather patterns, we know this has threatened some of the resources that Indigenous peoples would traditionally use and obtain from the land. So in response, the Indigenous woman that you see here on this slide, her name is Dawn Morrison. She founded an organization that works towards supporting Indigenous food sovereignty with a focus specifically on using traditional methods for food production. So as I was reflecting on this, I was thinking about what we've seen over the past number of months and how we are all grappling with the climate crisis that's happening around us. And at the same time, I thought it was really important for us to recognize the additional impact that this crisis is having on Indigenous communities across our country. And I also thought it was important for us to acknowledge and celebrate the work of organizations like Dawn's. Back to you, Tara.
Thanks, Mahalay. So just a reminder that our sessions build on one another, and thanks to our planning committee who continues to be able to plan for these sessions and provide you with the most up-to-date evidence. We're always looking for new members, so if you're interested in joining, let us know. And wanted to remind folks that all our past recordings, as well as the recording from today and the resources and slides from today, will be posted on our website, usually by the end of the day. So if we go to the next slide, I think we're just about ready to introduce our speakers for today. I'm going to turn it over to you, Dr. Moore, to introduce yourself first. We'll go to the next slide.
Good morning, Kieran Moore. Honored to be invited to speak with you. In terms of disclosures, I was the lead for the CIHR Canada Lyme Research Network. I have stopped that position as I transitioned to the Chief Medical Officer of Health. And I have previously, quite remotely, received a small honoraria for providing input and insight into the epidemiology of Lyme in Ontario and Canada for Pfizer as they were contemplating a vaccine. Have no further association with them and have previously received an honoraria from the OCFP. Otherwise, I have no other disclosures or conflicts to declare.
Thanks. Pleasure to have you today. And Dr. Moore, did you introduce your position there? I think you did, right? That you're the Chief Medical Officer. Wonderful. And so Dr. Warshafsky, over to you.
Yep. Hi, good morning, everybody. I'm Dr. Daniel Warshafsky. I'm one of the Associate Chief Medical Officers of Health, working for Dr. Moore.
Wonderful. Mahalay?
Thank you. My name is Mehle Kuminen. I'm the president of the OCFP, and I also serve as a chief of family medicine at the Cambridge Memorial Hospital, neither of which poses a conflict for today.
And I'm Tara Kieran, and I'm lucky to be a researcher, have a number of grants that I've received, listed those there, as well as honoraria, none of which I think pose a conflict for today. I wanted to just remind folks that I think this is going to be a busy session. We're going to cover a lot today. And if you have questions, please do put them in the Q&A. We also really appreciate all of your interactivity, your suggestions, your experiences, the resources that you recommend, and appreciate you putting those types of things in the chat. So if you want to share comments, resources, put those in the chat, but please do put your questions in the Q&A. And again, there's a lot of people attending today. I believe we have over 700 registered. So we're going to be taking the questions that have the most upvotes. So rather than putting in your own question, please do upvote someone else's. Next slide. I just wanted to go over kind of the outline for today. We're going to start by hearing from Dr. Moore. He's going to tell us about the latest epidemiology about COVID in the province. He's going to talk about the new variants, and he's going to remind us kind of about infection prevention and control precautions that are recommended as we go into the fall. We'll then break after Dr. Moore for some questions related to those topics, and then we'll turn it over to Dr. Warshafsky, who's going to talk about the new COVID vaccine, and then we'll talk a little bit about therapeutics and testing. Again, we may break in the middle of that depending on the types of questions so that we can get lots of questions in, for example, about the new vaccine. We know questions are a big reason why you joined today. So although the original session was scheduled to 9 a.m., we are flexible to go to 9:15 depending on the volume of questions and how the dialogue is going. But we'll certainly get all of the main information shared with you before 9. All right, so without further ado, I'm going to turn it over to you, Dr. Moore.
Thanks very much. Next slide. So in the next 10 minutes or so, will just try to review the very complex seasonal respiratory epidemiology of the major viruses that impact the health of Ontarians and give you some projections that our team has been reviewing in partnership with Public Health Ontario. Next slide. And then Daniel, as Tara has said, will review some of the therapeutics as well as the vaccines that we have in our armamentarium to protect Ontarians. So we look at daily dashboards of data that look at both COVID-19, influenza A and B, and RSV. Some of these dashboards and information is also publicly available at Public Health Ontario's website. If you look at respiratory season pathogens, and Daniel will provide a link to their website, you can look at both the assessment for Ontario as well as regionally. So that may help you understand the local epidemiology. But these are some of the data points that we look at. And clearly for COVID-19 over the last 8 weeks or so, 6 to 8 weeks, we've been seeing a rise in activity, mainly from an Omicron group of derivatives that I'll show you secondarily on EG.5.1 and FL1.5. So an alphabet soup of names of all derivatives of Omicron. And the XBB group as well. So we've seen an increase in activity, the percentage of tests that are positive. We've seen an increase in the wastewater signal across Ontario. It is not as dramatic as previous waves and not as having as significant an impact on our hospital system because of the great population immunity that together we've built through a strong immunization strategy and hybrid immunity across the population now. Our outbreaks in the high-risk settings, such as hospitals and long-term care, are stable, but we are seeing a rise in admissions. 60% of admissions are causative, 60% are not causative to the general medical ward, and 40% are not causative to the intensive care unit. So they test positive, they may have had an illness in the past, or they may have an exacerbation of some other illness. So you have to understand the data a little deeper to really understand the full impact of COVID-19 on the healthcare sector. But it is a wave that is tempering. Normally these waves, if you watch the undulation of them over time, have been decreasing in their impact on the health system as well as on the population because, as I said, that underlying immunity that we've built through both immunization and natural exposure, so the hybrid immunity. So that's a good sign as we head into the winter that these waves are decreasing, but we are heading indoors. We are being in closer contact in schools, colleges, universities, in our home settings. And so we may have some propagations. This wave will most likely start to diminish soon and then fade into October. And then we'll wait for the next pathogen to come along, the next variant of interest or concern as a result of ongoing mutation of this virus. For influenza, we have not seen any significant activity, nor have we seen any significant RSV activity. That's not to say we don't have people admitted to the hospital. We have roughly 20 with influenza and 20 with RSV admitted to the hospital at this current time. But at the peaks, we had 300 of influenza and or RSV at a minimal when we start to see active transmission of both of those viruses. So we're anticipating an early start like we had last year, perhaps in November, of influenza. And when we look at the Southern Hemisphere, it was a mixed year of A and B activity. Roughly 60% H1N1 and 40% Victoria strain of B. So for this year, we're happy to say the quadrivalent vaccines do have protection. And when they did a vaccine effectiveness study of the Southern Hemisphere vaccines, there was relatively good protection. And Daniel will go over that with you shortly. For RSV, we don't expect as severe an impact. And we've watched the Southern Hemisphere RSV activity was more muted than the previous year, where we didn't have significant community immunity and from previous exposure to that virus. So we hope and anticipate that there won't be as severe an impact. Although I want to tell you, we've been working with the health sector to, especially the pediatrics, to build their IMS capacity, to build their ability to respond and work as a coordinated system of the 5 major pediatric hospitals and the 31 community hospitals that provide pediatric care. And I'm happy on the progress that we've made. Next slide. These are also epidemic curves that you can see. I just wanted to point out for this influenza A in the middle curve here, you can see how aggressive the H3N2 year was last year. It was an A dominant year that typically gives a very high and peaked activity of 12 weeks minimum impact on our healthcare system, our emergency departments, your urgent care centers, and the ICU. That was quite dramatic and started earlier than any previous traditional influenza seasons. We don't anticipate as severe an impact like last year, so that very tall and peaked activity in November and fading by January. It will be a more muted influenza A and then a B year, so it'll go on longer, sadly, in affecting your urgent care centers, but be less dramatic an impact on the healthcare system. For RSV, again, we expect it to be more muted, less impact as we've built significant community immunity. If you look at the wastewater signal, and this is publicly available, updated every Thursday at 4:30 at the PHO website, it continues to go up, but you can see these undulating waves of activity through wastewater signal, through admissions to hospital, through positivity. That's the natural process that we're seeing now with COVID. But if you look at the bottom right, you're seeing a less and less impact on the healthcare system, thankfully, through the combined efforts of our society to protect each other through vaccination, access to therapeutics, as well as the hybrid immunity that's been built up. Next slide. So those are some of the key metrics that we monitor on a real-time basis. As well, these data points are accessible through ACEs. So Daniel will put the link. The acute care enhanced surveillance system that's run out of my prior health unit at KFLNA, and it monitors real-time emergency department visits. This would, I think, correlate strongly with what you see at your urgent care centers and your after hours, and it breaks it down by age groups to give you an early signal broken down by the 34 regions of the province that you can access the activity levels of respiratory illness in general. So this would be the correlation of the rhinoviruses and the RSV, influenza, and COVID. Right now it's at a low, steady state. It's equal to prior years, but we do anticipate this taking off And it's a very good signal for you to be monitoring at a regional or local level to understand the impact on your patient population, your hospital, but also your practice. And that's updated in real time through monitoring of the emergency department visits as they occur by the second. Next slide. This is the change in the virus over time. So the darker you can, or lighter color at the bottom here was the XBB. The XBB variant of COVID-19 now has diminished, and we're seeing these other all strains of Omicron, the FL, the EG.5.1, and Daniel would call this a salmon color. I don't know my colors well, but the salmon color taking over from the purple. It is now the new variants that we're seeing. They are all related, the XBB, FL, and so we do anticipate the vaccine for XBB will provide coverage and care, and Daniel will go over that statistic to be able to show immunologically that there is cross protection against these variants, but they're coming fairly fast and predictable 8 to 12 week waves now. Next slide. For the, okay, we're not showing the BA2, but if the bottom part is that alpha, beta, gamma, delta that we went through, so the original strain plus all those waves that we went through in 2021, 22, and then the upper diagram is the offshoot of the Omicron variants. And we've been living through derivatives of those Omicron variants over from January 22 all the way through to now. And you can see that the evolution is such that we need vaccines that keep up with these significant changes and mutations in the vaccine, in the virus. So we are now preparing an XBB vaccine that we hope will better protect against this new progressive lineage of Omicron, which clearly becoming the dominant strains. They must have evolutionary benefit as compared to the previous strains in terms of their infectivity, but we're fortunate that the severity hasn't increased. And we often ecologically see when the transmission of a virus increases, the severity decreases, and they're mainly binding to the upper respiratory mucosa and not binding lower respiratory mucosa, which is where we have the higher morbidity and mortality. Next slide. This was the BA2.86. You may have heard of it, and it was concern from it because of the multiple mutations. So in the top is the original HU.1 Wuhan strain, and multiple derivative changes right down to BA2.86. So you can see any amino acid change in this protein structure of the spike. BA2.86 can change its ability to bind to our respiratory mucosa. It changes its overall shape of the spike protein, which is the main receptor or main protein that binds to our receptor domains. And those are the changes that we monitor on an ongoing basis for most of these pathogens. There was concern about all of those changes that occurred in this variant, but it does not appear to have any advantage over the other strains that are circulating. And actually, the EG.5.1 has a competitive advantage, and this is not taking over as a dominant strain despite the mutations. And so it was a concern. But we also, Daniel will update you that we believe that the vaccine does give cross protection against this variant as well. Next slide. For infection prevention and control, so I've given you an outline of when we expect influenza to rise. The RSV will be coming back in the next several weeks, as it started in the southern United States and is propagating northward as we speak. And so the foundational infection prevention and control skills will remain in place. Of good hand hygiene, cleaning high contact surfaces, very important for RSV and influenza. Active screening for all acute respiratory infections, given that it'll be a mix of infections and other communicable diseases. Should have processes by telephone reception, email, and active screening once we get into the active respiratory season. And an emphasis was placed by Public Health Ontario on doing that point of care risk assessment, either as they enter your clinic or as you enter a room, always assessing the risk for you as an individual. Do you have a fever? Do you have chills? Do you have a cough? Have you recently traveled? Have you been a high-risk contact? Asking those types of questions and then adhering to the best practices that are associated with each of the pathogens or risks. And the next slide. These would be the contact precautions that are available through the infection prevention and control for clinical office practice, whether it's contact, droplet, or airborne, and the appropriate pathogens and activities that you can put in play. This is a very good reference document. I would think that as we see the co-circulation in early November of influenza, RSV, and COVID, that we should be putting all of our precautions in place. And that would have to carry us through for all the way through to March of the full respiratory season, as we anticipate influenza B being active all the way through to March. Next slide. These are, again, additional resources that can guide your office manager, your staff in terms of best practices. So we thought we'd include these for you. And you also have your local health unit that will be monitoring the local epidemiology that can give you guidance on where we're at in the epidemic curve of all of the major pathogens. And the IPAC hubs can provide you with guidance and support as well. Next slide.
I think that's the end of your section there, Kieran.
Yes.
So thanks very much. That was a terrific update. I know we've got lots of questions in the Q&A, and most of them actually are going to be answered by Dr. Dan Warshafsky when he's providing his talk.
I was foreshadowing, Tara. I was trying to build suspense.
Oh, yeah. So there are a couple of questions, though, that I wanted to put to you, Dr. Moore. So the first is related to how much, so you talked about the epi and how reliable though are the case numbers, given that many people now are just testing at home with rapid antigen tests, not reporting. So how can we be how can we rely on those numbers that you provide?
So we still do have very good surveillance system. We're monitoring all the top of the epidemic pyramid is the deaths. Then it's ICU admissions, then it's hospitalizations, then it's the test positivity, and then the syndromic data. So we still have that in play. We still have excellent genomics across Ontario, where we can do the genomic analysis of all of the circulating strains. So very robust still, and a significant proportion of all positive tests are put through that genomic, given that we built the capacity. So our surveillance remains robust for these. I absolutely acknowledge that the amount of testing has gone down, but our pyramid of data remains very good, and we've added good and I think much improved influenza surveillance as well as RSV surveillance.
Thanks, Dr. Moore. So then there are also a number of questions just about your plans for public communication. I think there are a lot of colleagues who we're worried that the public doesn't really understand the risks. What is the plan for communicating about the new vaccine, about masking? And also even, I think there are some comments about, what is the goal now moving forward too? Is it just to, I think people are commenting about hybrid immunity, and, it's not just about getting, hybrid immunity, but maybe we really want to prevent long COVID as well, and that there are risks of long COVID, including vascular risks. And so I wonder if you could speak to, the public communication, as well as sort of the goals of the public campaigns.
Yeah, so we will have a robust communication strategy at a population level in coordination with our federal partners, talking about first, staying up to date with your immunizations, and that will be started. It started, as you heard, that Health Canada approved the Moderna vaccine just two or 3 days ago. Then our federal colleagues went public. I did a bunch of press interviews yesterday, but we also have a multimedia social communication strategy that we'll look at first, staying up to date, protecting yourselves, your family through immunization as the best means of preventing all of the issues that you talked about, Tara. Also getting the vaccines at the same time, influenza and COVID, so it's safe and practical to get them at the same time, and those vaccines will be available at the end of this month, going all the way through to November. We want individuals to be protected well in advance of the rise in cases. And then we'll be talking about how best to protect yourselves. So the layers of protection, which does include masking, so hand hygiene, distancing, staying at home when you're sick, cough etiquette, and masking, especially if you're high risk. Then we're going to be communicating about when and how to seek healthcare through 811, accessing it, and having strategies to prevent emergency department visits through ED diversion, acknowledging the roles that primary care plays, our pharmacy plays, and we still have some clinical assessment centers. So we'll be in a staged and phased rollout of that communication, which will be echoed by local public health agencies and in sync with our federal colleagues.
Great. And so I think part of the comment here is more just that it sounds like there's a lot of focus on not getting infected, partly to like prevent hospitalizations, and we don't want acute illness, but that there's also the prevention of long COVID, and wondering if some of that communication takes that into account.
Absolutely. So during many interviews yesterday, we were emphasizing the benefits of vaccination, that there is a benefit of vaccination to prevent especially in children, multi-system inflammatory syndrome, long COVID, and the risk of hospitalization and severe outcomes. So there is a benefit, multi-benefit from being immunized, and I'm sure Daniel will echo those.
Wonderful. All right, so you can take a look at the Q&A, Dr. Moore. Well, I guess I'm going to turn it over.
We always emphasize in the layers of protection, ventilation and filtration as well.
Absolutely. So I'll turn it over, though, to you now, Dan, because there are a lot of questions, obviously, about the new vaccine. And in particular, I know a lot of the questions, Dan, are about the timing of the new vaccine in relation to when you got your last shot and or when you had your last infection. So when you cover the new vaccine, I hope you can address those questions as well. And maybe we'll just pause after the COVID vaccine, or actually, no, why don't you go ahead and talk about all of the vaccinations, because there are also a number of questions about RSV.
Sure, thanks, Tara. So let's dive right in. Next slide, please. So this year, given the timing of when we have products coming available, we're able to roll out essentially a combined COVID and flu program. As per normal flu seasons, as we've done previously with COVID when supply was more limited, initial doses are going to the most vulnerable populations. So starting off with hospitalized individuals and staff, and then long-term care home, elder care lodge residents, staff, and caregivers. As soon as those populations and settings receive their doses, immediately we'll start getting out to all of yourselves, as well as pharmacy, to get the rest of our high-risk populations. And so the whole list is here, and I'm sure all very familiar with it. The main things I want to just flag from the list are that for COVID-19 in particular, children under 5 aren't at higher risk, but they certainly are for influenza. And since we're trying to promote co-administration as much as possible, children can come forward and receive both of those vaccines when they are available. And there are slight differences in terms of NACI's high-risk underlying medical conditions between flu and COVID, and so the links are in here if you have any interest in looking at it. And then healthcare workers and first responders included as well in here. If you can go to the next slide, please. So just the overall timeline. So we are expecting to get approximately 350,000 doses of the Moderna XBB COVID vaccine sometime next week. We don't have official dates yet. And then the goal will be that the week of September 25th, those along with our initial flu doses start rolling out to, again, those highest risk settings, hospitals, long-term care homes, and elder care lodges. As soon as those settings have their supply, then again, as I said, it opens up so that realistically, we're talking about probably the first week of October, maybe second week of October, getting to yourselves, primary care providers, as well as pharmacy, for vaccination of our highest risk individuals as well in the previous list. Currently, the plan would be that by October 30th, we're able to open up both influenza and COVID-19 vaccination to the general population at large. I would say that that exact timing is really dependent on when the supply does come into the province. And if we have supply available earlier, then that date would be moved up so that we could make sure we can get people their vaccines as soon as possible. Next slide, please. I just want to talk very briefly about the new monovalent product from Moderna. So it's very simple in a number of ways. So first of all, it's authorized for individuals 6 months and older. So it's the same product for all those individuals. The difference would be the dose. So for individuals who are over 12, it's that 50 microgram dose, so it's 0.5 ml. And for anybody under 12, it's a 0.25 ml to 25 microgram dose. The other thing that's also come out from the new product monograph is actually a simplification of the primary series, where if you haven't been previously vaccinated, it's just a single dose that would be considered getting your primary series, whereas except for individuals under 5, where if you're not previously vaccinated, it would be 2 doses 4 weeks apart. There wasn't specific guidance in the product monograph about for immunocompromised populations, but we know that NACI is looking at that right now, and we hope to get their guidance for those populations as soon as possible. Next slide, please. I want to share this one, partially because I wasn't sure if we'd actually have the data on the Moderna vaccine, but we do, and I will get to it. But this is a really good study that came out just in July, looking at all of the previous different vaccine types we've had, so including the original strain, BA1 and the BA4/5 bivalents, and looking at how effective each of those different products were, depending on how well they matched. So essentially, you can see here that an updated product that's adapted against any of the newer strains provides very good protection, particularly in the earlier days following vaccination up until about 6 months out, which is what we're very familiar with. And then we start to see a bit of a quicker decline in immunity. The decline is much slower and the protection is much better for more severe outcomes, as we know, for hospitalization and death. I think one of the key things to note here is the difference between a homologous, so a perfectly matched strain, and then a heterologous or a not well matched strain. And the differences are not very big, particularly as when it's earlier on in your time following the dose. So a dose adapted against any strain is going to give you much better protection than not getting a dose or the ancestral Wuhan initial strain dose. But obviously we do see a slight difference in improvement in strains that are matched. The keynote here is that it's not like flu, where a mismatched year you could have 0% effectiveness. We're talking about at kind of the most difference, maybe 10, potentially 15% at most difference in effectiveness, and that's as you get out many, many months from when you received your last dose. Next slide, please. So this is the data that we have for the newest Moderna XBB product. We unfortunately don't have efficacy data yet, just given that the Health Canada has moved towards essentially the flu model of authorization, which is display of neutralizing antibodies. But Moderna did a good job of covering a very wide range of different COVID variants and subvariants to see what the protection was like. And the ones I've highlighted here in the circles are the EG.5.1 that Dr. Moore was speaking to. That's the Iris strain that's currently dominant and increasing within Ontario and Canada. And the other one highlighted is the BA2.86, which is the one that, again, as Dr. Moore said, has been noted elsewhere, but doesn't seem to be taking over quite as much. What we showed here is that when you got a dose of this new XBB product, it significantly increased neutralizing antibody titers across the board against any strain. So you can see it's actually in someone with no prior infection, it actually did an even better job against the BA2.86 than against EG5.1, about a 14 times increase in titers or 11 times increase for the EG5.1. For individuals with a prior infection, which is, to be fair, the vast majority of individuals in Ontario at this point, we still see a really good increase in neutralizing antibody titers. So we expect that the protection is going to be very, very high across the board against the total variety of strains that we are seeing in Ontario right now. Next slide, please. Oh, that's backwards. That's more backwards. Okay, quickly into the products that we have for our flu program this year. So we have 4 products available. As Dr. Moore is saying, in terms of strains that they're covered, they are covering the H1N1 strains that we saw in the Southern Hemisphere, as well as the B Victoria strain that we saw. As a quick reminder, the Flu-Laval and the Fluzone, like regular quadrivalents, are indicated for anyone over 6 months of age. The enhanced products, so that's the high dose as well as the adjuvanted, are recommended by NACI for individuals over the age of 65, as they've both shown to have superior protection for individuals in that age group over the standard quadrivalent regular dose. Next slide, please. This is the data that we have right now on the effectiveness of the flu vaccine from the Southern Hemisphere. This is primarily from South America, so we have Brazil, Uruguay, Chile, Argentina covered here. Excuse me. Just to highlight that we saw pretty good effectiveness this year across the board against flu. So overall effectiveness was about 52%. Against hospitalization. So that's a fairly decent year that we have for our flu vaccine. Obviously, better protection for children, not quite as good for older adults, but still showing that it's a good match year and was in the Southern Hemisphere. And given that what we have to date is still showing the same strains likely to be coming to Northern Hemisphere that we've noted, and the same vaccine products, we're expecting to have a very good match as well. So that's quite fortunate. So RSV, and I saw there were a lot of questions about RSV in the chat. So Ontario is rolling out the very first, this is all in a news release that went out yesterday, so we're getting it kind of hot off the press, the first publicly funded RSV vaccine program. It will be targeting individuals over 60 living in long-term care homes, elder care lodges, and some retirement homes. And as far as we're aware, it's the first program globally that's offering our RSV vaccine publicly funded. There will also be some supply available on the private market, and pharmacists will be able to administer that as well. I just very briefly, before I get into more about the RSV vaccine, I know that we had questions previously about the new monoclonal antibody nirsevimab. Unfortunately, that supply won't be available in the province until much later in the year, December or January. So the existing pavizalizumab program for high-risk individuals, and the link is here, is still active in the province. So in terms of timing for the RSV vaccine, just of when we might have it available for the publicly funded program, it's not quite clear. We don't have exact dates. We're still waiting on supply, unfortunately. We're expecting it to be available sometime in mid-October to go up to those highest risk populations. This is just a little bit of the data quickly and details on the product itself. So again, it's authorized very recently, just a month ago, for individuals over 60. It is an adjuvanted product, and it does require reconstitution. And it comes in either single dose kits or 10 packs. The data on the right side is what we have in terms of efficacy on the product. And so it actually showed very, very good efficacy. We're quite happy to have it. So overall, it was about 82% against any infection with RSV, which is really, really wonderful. About 94% against severe disease and hospitalization. So again, looks to be a very, very good product from the studies we have so far. The other really interesting thing to note, and again, it's to note because we're still getting more data, is that protection seemed to last up until the second season of RSV as well, from what they observed in the study. So they actually went out to almost 2 years, so able to capture 2 RSV seasons, and it showed about a 77% efficacy still at the second season. So it's a big question of, you know, whether this will actually need to be a yearly vaccine or not. But we're going to be following very closely the data that comes out to see what would be the best for this product. I think that's everything I had on vaccines, Tara. So we can
why don't we pause, because I think that was a lot of information and there were a lot of questions. So let's try and take some of those questions now, and then we can talk. Maybe actually I might ask you to talk about testing next, because there are a lot of actually questions about testing as well. But yeah, so what I heard from you, Dan, is that, you know, it's a combined COVID flu vaccine program this fall for everyone 6 months and above, that hopefully by the first or second week of October, that our primary care offices will hopefully have the vaccine for both flu and the new COVID vaccine, if we want to give it in our offices for high-risk individuals, and that by the end of October 30th, we could hopefully give it to the general population. So just want to confirm that I've understood correctly.
Yes, absolutely.
Great.
And again, if supply comes sooner, we'd hope to be able to open it to the general population even sooner.
Great. And it sounds like, just emphasizing a few key points here, that you said that for adults, you know, even if you've never gotten a COVID shot before, it's just going to be 1 dose. That's
what the Health Canada authorization was. To date, NACI has commented that they are accepting this product for primary series as per Health Canada, but they still need to comment again specifically on immunocompromised populations and some other high-risk groups.
Okay. And we're able to co-administer the COVID vaccine and the flu shot in the same visit. Is there any, so let's say though that they're occurring on different visits, because let's say as a family practice, you give the flu shot and then they go to the pharmacy to get the COVID shot. Is there kind of an interval between those two that we need to be aware of, or can it be given at kind of any time interval?
Yeah, no, good question, Tara. So for COVID and flu, we have a lot of experience now. There's no time interval that needs to be waiting between those products. They can be the same day, 1 day apart, any time interval you choose. I should emphasize that for the RSV product, given as a new product, we are strongly recommending at least a 14-day window between receipt of any other vaccine, the RSV vaccine, to help us make sure that we can do AFib monitoring in the best way possible for any potential adverse events that do occur after that one.
Okay, great. So then just going back to the COVID vaccine, lots of questions about timing. So let's say someone had their COVID shot 4 months ago. Can they get it, can they get it now, like if it was available, or should they be waiting for the 6 months?
Yep, so NACI still recommends that 6-month intervals providing the optimal protection, but they specifically state in their recent recommendations that a 3-month interval can be used as a minimum valid interval. Any less than that is very, very close, and we lose significance in terms of the effectiveness. But 3 months was considered a valid interval, and so for anyone who's high risk, that absolutely we would happily have people getting at that 3-month mark.
Right. And so similarly, if you've had a COVID infection, so let's say you had a COVID infection 4 months ago, can you get the COVID vaccine?
Yeah, so with COVID infection, there's not a hard and fast rule in the same way. So NACI does recommend that 6 months. The other thing I would note for COVID infection is that if it's only been 3 months, you probably just had the XBB strain or very closely related strains that are circulating now. So getting the boost, the new XBB product wouldn't be quite as big a difference, given that you just had a very, very similar infection. But again, it's not quite a hard and fast rule for last time since infection. It's a recommendation of 6 months.
Great. And so you showed us some data related to the new COVID vaccine. Looks like there's some good immunogenicity, but wondering if there's any kind of, it sounds like there probably isn't data, but asking the question if there's data or if it's known around how it might protect against transmission.
So that's a great question. And unfortunately for COVID, we don't really have immune correlates of protection directly, like we do for other products, where we can say if your titers are X high, you can't get the infection at all. What we have shown is that higher levels of neutralizing antibody titers absolutely decrease the risk of transmission and of getting any infection. But given the quickness with which strains change, we can't say a number that directly attaches with it from just having neutralizing titers, which is quite unfortunate. What we can say is that higher titers certainly improves the effectiveness of the product, decreases your risk of transmission, decreases your risk of any illness, decreases especially your risk of hospitalization and severe disease. So if you saw in the graph I had comparing different doses, obviously the far left side was kind of transmission, and that is much lower comparatively than against hospitalization and death.
Got it. And then there's a lot of questions, Dan, about kids, because as you know, previously, I guess for 6 months to 5 years, there was more of a may get the COVID vaccine before. There was a lot of vaccine hesitancy. I don't know if that's the right term for it really, but just parents reluctant to get their kids vaccinated and very low uptake of the vaccine among kids. So just wondering if you could comment on the change in recommendation for kids for this vaccine, where I understand it's a recommended vaccine for kids, and also whether, what advice you have around communication around that, and whether your office or the province is going to be specifically kind of targeting kids.
Yeah, it's a really good question. I hope Dr. Moore can weigh in and give his thoughts as well, because it is complex, I would say. So NACI, in their most recent iteration, did recommend for everybody over the age of 6 months to receive a dose of the new product this season. In terms specifically of kids, and particularly those under 5 years of age, we also know that they're not nearly at the same level of high risk as they are for flu, for example. So it is a bit more of a question for COVID-specific vaccination than it is for flu. What we have shown, though, over, again, the many years now, is that these are incredibly safe vaccines. So the benefits of receiving the vaccine certainly outweigh any potential risks. And importantly, receipt of the vaccine decreases the risk of, as Dr. Moore said, things like multi-inflammatory syndrome or long COVID. So even though kids don't get as severe disease, they can still get long COVID, and the vaccine will reduce their risk of long COVID symptoms, certainly. So that's part of the reason why NACI is broadly recommending everybody in that age group over 6 months to get one of the new doses. But Dr. Moore, I don't know if you have more you'd like to add.
No, I agree with that, Daniel. If there's resistance, especially for those children with any underlying medical illness, that would be the core group that you really want to protect. And any additional immunization would be wonderful, but it's really those with any underlying risk that we want to protect.
Thank you. So a question not related to vaccines, but just since Dr. Moore, you just answered this last one. There are a few questions just about whether there's going to be any recommendation or ask to go back to universal masking in any setting, and wonder if you could speak to that.
We don't anticipate any mandatory masking. That would be a decision of government. We are working with our hospitals to make decisions when we see influenza, RSV, and COVID co-circulating, that they'd want to have in all clinical settings masking and the best protection to avoid outbreaks and or transmission within those clinical settings. So we're hearing hospitals making prudent decisions already to best protect their patients, and we'll give them guidance as well as their local public health agencies, but they have significant competence to make those decisions given their expertise in IPAC.
Thank you. And then a related question around kind of, who to target this vaccine campaign to. Should we be focusing this new COVID vaccine rollout to the 5 most at-risk populations, pregnant, over age 65, immunocompromised, chronic illness, congregate setting, as opposed to young, healthy people? It seems the latter aren't that interested based on the previous data anyway. So that's from one of our colleagues.
I'll be right up front. It is a risk-based strategy. We don't have 16 million doses. We purchased roughly 5.7 million, anticipating that we'd have equal coverage to our influenza, which is roughly 50–60% of the over 65s, and 30 to 40% of the general population will want to come forward. Our real target populations are those that can have the most severe outcomes. Anyone with an underlying illness, anyone over 65. And the First Nations, Inuit, Métis, racialized communities, pregnant would be key as well. But it is more of a risk-based strategy of hopefully the more willing to come forward to be vaccinated.
Right. And so question is, do we still have to use the COVAX system if we want to do COVID vaccines with our flu shots? It is a barrier to doing them in our office.
Yeah, at this time, yes. It's the main way we're tracking who's gotten doses, what our uptake is like, and monitoring inventory. So currently, it is still a requirement to be administering COVID vaccines.
He's also asking to describe the responsibilities of regional public health units for the administration of immunizations in retail pharmacies. If regional public health units do not have any responsibility, then who is responsible for quality assurance, e.g. cold chain, adherence to best immunization practice, and for equitable distribution of vaccine products to all immunizers, including family practice?
Oh, you're muted, Kieran. I thought you wanted to do it. Sorry.
Well, I'll start. Local public health agencies are obligated before the start of influenza season and on an annualized basis to do an inspection of all of our immunization providers, including primary care and pharmacists. So that inspection is, as you know, quite rigorous in terms of maintaining cold chain. If there's any break in cold chain, they must consult with local public health agencies, and we would give guidance on what products could be used in future or what products have to be recalled. So that relationship with all immunization providers is robust and remains. The oversight otherwise would be with the College of Pharmacists on the competencies on vaccine provision. Daniel, anything to add to that?
Just again, so any pharmacy that signed on for the universal flu program and COVID for this fall, immediately after that, that's when the public health units would go and ensure that they've done their cold chain and inspections, everything to be sure that they're ready for the season. So everybody who is administering COVID or flu vaccines this fall has had a recent inspection by a local public health agency.
Thank you. I mean, there is a question also, do pharmacies get these vaccines before primary care?
It is variable by region. It depends basically how quickly the healthiness can get it to those highest risk settings. I would say most of the time, primary care gets it before pharmacy, particularly for flu. So for flu, there are actually dates later in October where pharmacy gets their lots released, and we would expect that for the vast majority of primary care providers will get their flu earlier. For COVID, it's roughly the same time, again, as soon as those highest risk settings receive their products.
I'll note that one of my colleagues says it would be great if Covaxon was integrated into the EMR
Oh my
system.
goodness, yes.
But hopefully we can strive for that. So a few more questions. So is there any concern now, though, with this Moderna vaccine in youth in terms of increased risk of myocarditis, pericarditis?
Not that we've seen with the new products. And so Health Canada, when they're going through authorization, that's one of the key pieces for all of these that they've been following regularly. Certainly the risk for myocarditis and pericarditis, if you've already received a dose of COVID vaccine, is significantly decreased in any subsequent dose. And to the point that NACI is no longer even recommending any product preference if you've had a primary series already done. So it's extremely low, other than for the primary series where that slight preference does remain.
Great. Is there any work in making sorry, so another question. So actually, Julie, you can end slides for now. We'll go back to the slides in a moment. But so someone's asking, is there any work right now in making a central vaccine registry? How do we keep track of vaccines given in pharmacies?
That is the holy grail for all of us. So right now, COVAX Ontario is the only tool that we have in Ontario that we know up to date in almost real time the immunization status of Ontarians. Every other antigen that's provided, it's in your EMR, it's in the EHR of a hospital, it's in a pharmacy record. So we're working diligently to have one record for all Ontarians in integrating all this database, but it will take us time. It's remarkable that we're able to achieve it for COVID, and it clearly gives us an example where it can be achieved for all Ontarians, and it's the standard that I'm trying to bring to the government at all times when we have a new vaccine. One registry, one database, that from which we could also have better understanding of outcomes, better understanding of adverse events, better longitudinal monitoring and detection of risks like we did with the vaccine-induced thrombocytopenia that occurred. That was remarkable. That was picked up so early and quickly, and it was because we had one database to be able to find a 1 in 100,000 person risk.
I will say that Chandi Chadrasena from Ontario MD has said that the pharmacy vaccines do feed into the digital health drug repository clinical, and so you can see it on Clinical Viewer. So just a reminder to folks about that. I'm going to do a few more questions, and then what we'll do is we're then going to talk about testing, Dan, maybe instead of therapeutics, and talk about some of the resources from the OCFP, and then we'll take some more questions after that. But just a couple more questions here. So just, is there any plan to immunize frail elderly around the COVID vaccine? And the question actually even about RSV eligibility, it's people in long-term care, but how about the frail elderly?
Sorry, Kieran, go ahead.
No, you go ahead, Daniel.
Yeah, so for RSV, again, this is primarily supply limited to what we could get for the publicly funded program. So in terms of public funding for it, it will be for individuals in long-term care, as well as some higher risk retirement homes. And then again, if supply changes through the season, we may be able to get to some other higher risk patients, such as those who are ALC in hospital. We know there will be some level of supply in the private market available for individuals in the community, but it just wasn't something that we were able to obtain for our publicly funded program. For COVID, I maybe didn't totally understand the question, but absolutely, like long-term care homes, elder care lodges, retirement homes, those are top of the list in terms of where COVID vaccine doses will be going when supply does become available, to make sure that our highest risk older adults are able to get those products. And then for community dwelling seniors, they are again part of that high risk group that we strive every year for flu to make sure they can get their high dose flu or adjuvanted flu. And that's why we have that time period where it's just high risk individuals to come in to ensure that those individuals are able to get the product as soon as possible. I think that was the question, sorry.
Yeah, and will vaccination clinics be opening up again?
Yes, so local public health units will have vaccination clinics. We're not going to see them at the same scale, of course, as we did during the pandemic for a whole host of reasons. But absolutely, the majority of public health units are holding combined COVID and flu vaccine clinics this year, particularly in communities that are at higher risk with individuals who are racialized or marginalized, so that they have equitable access to the vaccines.
Okay. There are questions about whether the cold and flu clinics will open up. I will say that we were originally going to have Ontario Health here at this community practice, but it was a very full agenda. So they'll probably join us at a future one. And I think that question probably is better directed to them unless you have an answer about the cold and flu clinics, Dr. Morris or Warshafsky. Okay. I'm going to now take us to testing. And I wonder if we could go back to the slides, Julia, for the testing section of Dan's slides. There are a lot of questions about, where can patients get rapid antigen tests? And, because they're so limited, how can we confirm that if someone has COVID? So maybe Dan, you could talk about testing availability. Actually, Julia, can we just move to the testing section?
Thanks. I'll just start talking as we flip through the slides. But yeah, so part of the announcement yesterday that went out was also an expansion, in particular, of rapid antigen testing program. And so I have the details on the slide, but I think probably first I'll talk about PCR and access to PCR testing, if that's okay. So PCR testing is still broadly available across the province. Obviously, any of you can do PCR testing in your offices if you so wish, and the equipment to do so, including PPE, swabs, everything is available through that same PPE supply portal, and strongly encourage everybody to do it if they can. For individuals who aren't able to do it in their own offices, we do still have broad availability of PCR testing in the province. So there's over 500 pharmacies that are still offering testing. There are still assessment centers that are active through this year, about 30, more in the north and areas that are more poorly served generally. And most importantly, we have a PCR testing locator tool, and it's linked on this slide here. So that shows all of the sites across the province that are still essentially performing PCR tests, whether it's pharmacy, labs, assessment centers, any sites that would still be able to provide those tests to patients. So for eligible individuals who you think they need treatment, their RAT test was negative, absolutely go ahead, do the swab yourselves, send them to one of these sites through this locating tool so they can get their treatment. We also have rapid molecular testing in a number of sites, again, primarily across the north and some other higher risk regions in the province. So this is basically a rapid in-office turnaround PCR, and it does the whole swath. It does COVID and flu multiplex there. So it's really, really helpful for the sites that do have that. For the RAT access, so throughout the entirety of the summer, public health units have been ordering RATs to distribute out to the population in general. Sometimes it's through their own public health sites, but many are partnering with local community groups to make sure that those RATs can be distributed broadly. In the announcement just yesterday, there was a significant expansion in terms of who is able to access and distribute RATs to the population. So number one is to a broad swath of healthcare providers. So primary care providers have been able to order RATs throughout the summer as well through that same PPE supply portal. But as of the announcement yesterday, it opens up to additional healthcare providers. So it could be pharmacists, it could be allied health professionals, it could be physiotherapists, it could be dentists, anybody who is wanting to have RATs. Pharmacists, again, I will say specifically, they're strongly encouraged and to the point of almost being required to order RATs so they can distribute to patients broadly. In addition to those healthcare providers, there's also a program for specifically high-risk communities, First Nations and other Indigenous communities, and other sectors like healthcare, congregate settings broadly, so that there is access to those highest groups to have RAT testing available, like quick and easy access for them. So again, it has been a little bit more limited over the summer, but as of the announcement yesterday, it opens up very, very broadly so that anybody is able to get a RAT. test so that they can do it themselves at home. The one thing I'll note again is that a key message, as Dr. Moore was saying, was just stay home if you're sick. We know very often people might have symptoms, they'll do their test, it'll be negative for COVID, and then, okay, maybe I'm okay to go about my business. I think like we're all doing our best to strongly encourage people who are sick to stay home, regardless of whether it's COVID or any other respiratory illness. As Dr. Moore said, the burden from flu, RSV is significant as well. So really want people to stay home if they are sick. The testing is, again, most helpful to guide treatment, particularly for those who might be able to, who might benefit from it.
Thanks so much, Dan. One question, so a few questions. I just wanted to, first of all, emphasize a few things. So one is, of course, we as family doctors can do COVID testing within our offices. And I think the OMA has a great handout to support that we'll definitely include on the resource list. It sounds like there are multiple places where people can get PCR testing now, not just the COVID assessment centers, but many community labs. And I think more and more are going to be encouraged to do that, as well as many pharmacies. So there's lots of opportunity for people to get PCR testing if needed. And then just to summarize, the rapid antigen tests are going to be more and more available, it seems, or at least we can help our patients get them by ordering them for our offices and distributing them to our high-risk patients. Are there any other specific public access points that you would recommend, Dan, for the rapid antigen tests? Or is it just
again, so it's
CHU, but
yeah, so health units, and then they are distributing broadly to community providers within their regions, depend particularly which providers and community groups, but there should be many places. Pharmacy is going to be probably one of our major sources as well, now that that's opened up for pharmacists to be able to order them to distribute, again, broadly to any individual who comes in. And for those highest risk populations, again, specifically targeting product to get to those individuals so they have access.
Great.
It will be slightly variable by health unit, as things often are, to make sure that it's regionally matching, however the best way for people to access it is.
So I know that we're getting close to 9, but we all are going to go till 9:15 to try and answer as many questions as we can. Another question about the rats is, I'm hearing that the rats are not sensitive to the new variants when making a diagnosis for COVID in the community setting. Can you comment on this?
Yeah, and it's a really good point. And unfortunately, rat sensitivity has been decreasing for quite some time, essentially since kind of Omicron came. They're still very specific, which is great. So if you have a positive COVID rat, we are very confident that it is certainly COVID that somebody has. The sensitivity varies slightly by the variants. We don't have data on some of the very newest in particular, like the Urus or the BA.2.86, but it ranges around the 50% range in terms of sensitivity. So you'll catch half of them with a rat. So that's not great, but it is something at least that we can be using to try to get people access to treatment as quickly as possible. But certainly anybody who's high risk, that's why we have that access to PCR specifically for those individuals. And the turnaround time for PCR testing is quite fast. It's 24 hours for most locations in the province at this point.
Thanks. So there is one question about therapeutics, and I'll ask it to you, Dan, and then we'll go to Mahalé, who's going to be talking about some of the OCFP resources. So this was actually originally addressed to Chris Simpson, who's not here today, and so you may not be able to answer it, but I think the person who put the question says, can you please look into the possibility of prescribing Paxlovid to fill in advance of a trip or a holiday where Ontarians may not have access to closed pharmacies to get Paxlovid if they contract COVID? We do this for UTIs and herpes and PrEP, and some of their patients won't travel because they can't access Paxlovid if they get sick. So wonder if you have any thoughts about that, either yourself or Dr. Moore.
Yeah, I can start off with Dr. Moore, please. You can do that now. So there's no eligibility criteria for dispensing Paxlovid. If there's a prescription that comes from the primary care provider, then the pharmacy will dispense it. So, and I know you made a face because if a pharmacist is the one prescribing it, they would need to see the rat test or something to say positive because part of their assessment to see if someone has COVID. If they receive a prescription from a primary care provider, they will dispense it at your discretion as whatever you think is appropriate. You provide that prescription. It's your clinical acumen that's going into whether or not that person should be getting Paxlovid or remdesivir if they need remdesivir.
No, agree, Dan.
Okay, I think that's even different than what I thought. I thought that even as a family doctor, I think the last time we talked about it on this COVID community of practice, as a family doctor, even for that to be filled, you needed a positive RAT. So we could write a prescription and it can be on file in the pharmacy, but they couldn't fill it until they had a positive RAT. That's what our understanding was from our last few community of practices. So just wanted to confirm that that's different than your understanding, which is that.
Yeah, there shouldn't, again, for pharmacists to prescribe, certainly they would need a test. For them to just dispense, that it's up to you. Whether the pharmacist might have other specific requirements in place for their individual pharmacy, that's something I can't comment on, unfortunately. I don't know if there's like particular business practices they're using, but they should be able to dispense if you provided them with a prescription. You're saying the person needs Paxlovid now, it's up to you. Okay,
thanks so much for that clarification. And maybe we could put up Mahale's slides. I know I asked you about the sensitivity and specificity of like rats relative to variants right now. Any remarks on the expired rats, just as Julia's loading up Mahale's slides?
In terms of how well they work, the expired ones?
Yeah.
Probably not as well as the not expired ones, but I don't think we have really good data to say how good. I'll just say that in terms of supply, Ontario has millions of not expired rats. So, now that it's open more broadly, we hope people can get the ones that are not expired and use those.
All right, so I'm going to turn it over to you, Mahale, to just go over some of the resources that the OCFP's prepared to support family doctors just this fall.
Sure, thank you. I think with just all of the information that we are trying to absorb, we, along with our partners, have pulled together a number of tools and resources to try to support you as best as we can in your practices. So you'll see them listed here. I'll just maybe talk through them briefly. So the first is a checklist for you to prepare your clinic, both in terms of managing the surge and knowing what to do in terms of IPAC. We also have information and updates on vaccines and antivirals, so the management piece. And there's also a screening tool that you can use for your front staff so that you are ensuring you're screening your high-risk patients to allow for them to access treatment in a timely way. And then we also are pulling together or have pulled together a number of different patient-facing resources. So we have ones on prevention, caring for illness at home, and understanding risk. And we also have a tip sheet on knowing when and where to seek care, hopefully to help manage those same-day requests that we see as family docs. Next slide. So again, some more patient-facing resources. We had heard from our members that this would be something valuable so that we're not all reinventing the wheel. So a few more resources here. There's another one on staying up to date on vaccines. And then for those who are high risk, the need to plan ahead in case that individual does become unwell. And then again, managing respiratory illnesses at home. Next slide. So just in terms of where to find these resources, they're fairly easy to find on the OCFP website, and you'll see them be listed in my presence message that goes out today. Some of the patient-facing resources we will be posting on social media. You're welcome to amplify those. And we will be also out in traditional media, and I'll just take a moment to put a plug in to recruit any family physicians who may be so inclined to help with some of the media interviews and requests that we get. I think one of our staff will just put our email in the chat, and you're welcome to email us if that's something that you'd like to help out with. Thanks, Tara.
Thanks so much, Mahale. I also just wanted to remind people of Can Treat COVID, a national study where folks are, can be referred if they are positive for COVID, and they'll talk to a pharmacist and be randomized either to an arm of getting Paxlovid or not. And so this is a great way for us as family doctors to support us understanding, how effective this drug is. I am going to end slides for a moment and just going to go to a few more questions as we end off our series. There are some questions here about RSV that I wanted to get to. So actually, before we do that, I will just say there's been some comments around what the remarks around Paxlovid prescribing. And so just to say that we will follow up with your office, Dr. Moore, and others, just to clarify that and get it maybe in writing. It seems like many of my colleagues have been struggling with being able to get their Paxlovid prescriptions filled for their patients. Then I wanted to go to RSV. There are some questions about shared decision-making and if there are any tools to support us around, how we should be counseling our patients around this. So the vaccine costs approximately, I guess, $300. Are there any tools to help clinicians help decide if it's worth getting the RSV vaccine?
It's a great question. So we unfortunately don't have NACI guidance yet for the RSV vaccine. We're expecting that to come sometime later next year when we also have the other product that's available, will likely be authorized for maternal RSV protection. So unfortunately, we don't have that guidance to go from. At this point in time, I'm not aware of particularly clinical guidance criteria on how to recommend that for patients, other than just the data we have in terms of the effectiveness of those products. But I don't know if you've seen anything else, Dr. Moore.
No, if you look at the studies that have been published in NEJM, it's really age and comorbidity where there's the greatest benefit. 70 to 79, especially with comorbidity, there is a significant reduction in the risk for hospitalization or lower respiratory tract infection associated with RSV. So if you had to do a risk stratification, it would be older comorbidities that you may offer it to.
Great. And someone just clarified, I think it's $230. So someone did ask though, why is RSV not covered for everyone over 60 from an equity point of view? Obviously, there are many people who are marginalized and low income and don't have private insurance and can't afford this.
Yeah, so we're doing ongoing review of this vaccine, its cost effectiveness, et cetera, to try to ascertain whether we should move from the highest risk congregate settings like long-term care to a more population-based. NACI is going to help us with that guidance in the coming year or so. We're trying to coordinate research on this year's provision of vaccine to make sure that the efficacy matches the effectiveness that we may see. And so these are early days with a new vaccine that we wanted to best protect the high-risk congregate in a product that has limited access at present, limited production capacity. And we were able to purchase 100,000 doses for that population in particular. So 100,000 doses times 230 is a lot of money. And if we expanded it to a larger population, we'd have to be able to show that cost effectiveness and cost benefit.
Thank you. So a similar question actually is any update on when we might have a publicly funded campaign or offering for Prevnar 20?
So those decisions are, we take the recommendations of NACI and then we apply them to the Ontario position. Daniel, those decisions are being reviewed.
Yeah, I don't think we have a timeline. I think we're hoping for next fall. But that's probably the best I can say at this point.
Okay, great. So I guess another question just really relates to going back to the rats and sensitivity. We talked about how it's declining with new variants. How about if you do them 48 hours apart? Does that increase the sensitivity?
Yeah, if you do two tests 24 or 48 hours apart and they're both negative, the probability of it being COVID declines, and you may entertain other viruses or illnesses as the cause of the patient's symptoms. I heard Alison McGeer last time talking about 3 negatives pretty well is strongly against COVID, especially if they're spaced. That seems reasonable, but as Daniel said, a positive should be considered a true positive. And I hope your practices will take up the being a partner in making the RATs available. We'll certainly go further encourage our health units and our pharmacies to be active participants in the free distribution of these products.
I'm going to move now to a few questions that relate to schools and kids and their risk. So the first is just, are there any plans to roll out the COVID vaccine in schools?
We won't have a school-based program, no.
Okay. And someone's asking, and maybe I don't know if this is true or not. They said, why is the Ontario government removing the air purifiers from school when clearly COVID is not over and RSV and influenza are still real threats?
It was my understanding that the provision of HEPA filtration and the $600 million investment in filtration, improved filtration, is continuing, that there is actual funding to change the filters in the HEPA filters in an ongoing basis. So I'm not sure of that statement. They may be replacing the filters because there is actual funding for that.
All right. I mean, I think somebody also just made the point, and I'll read it here and you can comment, can we please address that children in schools are not able to access many of the tools we have? I am here. Attendance is promoted more than stay home when sick. CO2 monitoring shows poor ventilation. HEPA are not in classrooms or switched on. No masks, low vaccine uptake, not eligible for Paxlovid. I don't know if either of you wanted to comment just sort of on the risk of COVID for kids and how we protect them.
So previous years, the school boards are responsible for the ventilation, filtration, and the adherence of the best practices. Ministry of Education has already stated their best practices and their expectations. It was my belief the school boards are supposed to be making that publicly available on their websites. If you have an issue with a local school, as a family practitioner responsible for the health of your community, please go to your local school board and ask them. A health unit can be a secondary resource, but it really is a school board responsibility. The investment's been made by the Ministry of Education.
Thanks. So then there's a couple of questions just about Paxlovid. We didn't go into it in detail just because of the time, but someone's asking, is Paxlovid really safe and appropriate to be prescribed ubiquitously? Someone else is saying, will the ministry actually consider dropping all eligibility criteria for Paxlovid altogether? So yeah, I don't know what your thoughts are about that. And
from my belief, these are expensive medications. It's roughly $1,200 for a 5-day treatment. It's not something to be given out lightly. It should be a risk-based. It should not be omnipresent. There could be resistance patterns building if we make it more available. It really is to prevent hospitalization in the highest risk patients who have tested positive through RAT or PCR. That is the modus operandi of the program. This is a very expensive drug. We will be Ontario will have to take the costs of this going forward and after 2024, where we will have to maintain those criteria to minimize the overarching costs of the Paxlovid program. So please, this is a risk-based strategy. It's not for all patients. It really is to prevent severe outcomes of hospitalization in those individuals that have met those criteria. And Dan, anything to add?
Yeah, just so Ontario Health is going to be providing some updated guidance on who is best suited to receive remdesivir and Paxlovid, and it should be out very soon. It may be already today, but probably next week. And just to clarify, so there's not strict eligibility criteria to receive Paxlovid. It's clinical guidance as put out by Ontario Health.
All right, so Julia, maybe we'll put the slides back up. Just as we're ending, a couple of quick questions. One is, how long is the current recommendations to isolate if you're COVID positive? Either of you?
I'm sorry, isolation if you're COVID positive, as your symptoms resolve, so fever should be gone, all your symptoms should be improving. At that point, if you feel well enough, you can return to the workplace, at which point, especially if you're a healthcare worker, you should continue to be masked for up to 10 days. And I think that holds true for all respiratory viruses now. You have an infectivity even after your symptoms are resolved, so it makes sense that we make it a general recommendation. Anything to add there, Daniel?
No, and I think I saw Michelle already put that in the chat, and she knows all of that stuff. So.
Wonderful. All right. So, I know some people also had some questions about testing in their offices for COVID, flu, or RSV. Just a reminder that you can volunteer to be a sentinel physician and test for those things in your office, and we'll include that information. Also, just a reminder of this great service run by the Scarborough Health Network, Facts. They've worked really hard also to make sure that they have services that address marginalized communities that they serve. So if you're a patient, you have a patient who needs more counseling and time around the vaccine, please do refer to them. We'll go to the next slide. A reminder that Family Medicine Summit will be coming up in January. Abstracts are open. Next slide. And these are the days where it'll be happening on January 26th and 27th, and the registration is open as well. So next slide, we're just going to end off here. We're going to come back in 3 weeks with another session. Please do fill out our evaluation form and let us know what you want to hear about at our next session. I want to give a huge thank you to Dr. Dan Warshafsky and Dr. Kieran Moore for being here today. You provided us with a lot of up-to-date information, and you clearly have been doing a lot of work to prepare us well for the fall. And so thank you for that ongoing work and leadership that you're doing and for being here today. Thanks as always to my co-host, Mahalay Kumanen, as well as our back team of planning committee and supporters of the DFCM and OCFP. Again, our full recording will be made available by the end of the day on our website, along with the slides and a resource list. So please do check that out. You will be getting your main pro credits as well by email. So thanks to everybody for all the work that you're doing. Look forward to seeing you again in 3 weeks.